Neuroborreliosis is complex, but the thing is, it's probably going to present in primary care before getting to secondary care. So we do have a key role in primary care in recognizing these symptoms, which sometimes may be quite classic, sometimes may be very difficult. So just for anyone who didn't join previously, we've covered the fact that it's a bacterial infection due to Borrelia burgdorferi. It's caused by the invited infected tick, and when it affects the nervous system, it's called neuroborreliosis, and it's estimated that probably 25% of Lyme cases in Europe do affect the nervous system in some way. So we've covered a brief history as well before, the fact that at least the past century, some of these neurological and dermatological symptoms have been recognized in Europe, but maybe not on high enough on everyone's radar. In America, it was back in the 70s that Lyme disease was named after the town called Old Lyme in Connecticut, where a large number of children suddenly got diagnosed with juvenile rheumatoid arthritis. And in 1988, it was described as the new Great Imitator. That was a comparison with spirochete, with syphilis and other spirochete. And we've mentioned previously in presentations how it's the different genus species that seem to account for the different disease profiles in different areas of the world, with neurological and dermatological symptoms being more common in Europe, as opposed to arthritic and cardiological symptoms in the USA. It disseminates easily, it can cause immune dysfunction, and it can evade the immune system. And males are affected as commonly as females. We know there's a higher incidence in the southern counties and up in Scotland, and that neuroborreliosis may present really quite early after infection, or sometimes months, weeks, years later. So this is just a quick idea of showing you how primary school children seem to have a significant risk, and then later life 45 to 64-year-olds seem to also be significantly at risk. So stages we've also discussed before: the early localized, the disseminated, the late disseminated, post-treatment Lyme disease, which is the name produced by the Johns Hopkins Lyme Disease Center to describe persistent symptoms following standard treatment. And they're very keen to point out this doesn't mean post-infectious, it means post-standard treatment. And causes of these symptoms are still being investigated. Chronic Lyme disease is a bit of a controversial term, but it is really just describing the same issue of persistent symptoms. So we've already talked previously about erythema migrans and all the vague flu-like symptoms, which might be severe or very mild and easily go unnoticed. And neurological symptoms the infection may affect any part of the nervous system, peripheral, central, autonomic, or within the brain itself, affecting behavior and emotion. Can occur within weeks, months, years, and it really might be very difficult to diagnose. So you really need a high index of suspicion. So early diagnosis, early neuroborreliosis is probably going to cause radiculitis, inflammation of the nerve roots from the spinal cord, or inflammation of cranial nerves, or the brain. So radiculitis, cranial neuritis, meningitis, and that's often described as Banworth syndrome, when patients would present with all of those. And symptoms that they're going to present because of those infections are going to again be variable. Might be the fatigue, might be severe headache. Neck ache seems to be quite common even in early disease, and that kind of isn't necessarily a picture of meningitis itself or meningism, but just a neck ache is something a lot of people describe. Neuropathic pain can be mild, it can be quite severe, and it can often be related to where a patient was bitten, such as a patient describing being bitten on the neck and then within days having terrible shooting pains going down the arm on that same side. Another patient being bitten on the hand, and subsequently a month or two later developing agonizing radicular pain in the shoulder, which was just completely uncontrollable with all medication. Numbness and paralysis, it might be a facial palsy, but it might just be pain or tingling, double vision, droopy eye. Meningitis could easily get missed in that no one's necessarily looking for Borrelia when there's no evidence of any other bacterial infection. Patient might be a bit better because they've had one dose of an IV antibiotic. It's assumed to be viral and they're discharged home with a partially treated infection. Dizziness is quite common, hearing loss, tinnitus, and high sensitivity to sound. And early and late, early theoretically is before 6 months, but there's quite a crossover here as to what happens when. And patients can be describing any of these symptoms, which might be coming and going: unsteady gait, seizures, spasms, muscle fasciculations, which Gareth mentioned last week, and Millie, when she described her symptoms, not something a patient could easily mimic in some way. A cognitive dysfunction, insomnia, which is often seems to be a disruption of the circadian rhythm. GI problems, which again sometimes seem to be autonomic in their cause. Urinary symptoms again may be autonomic, and a POTS syndrome often is described late in many cases. But you're going to have to be really aware of this possibility, and any patients describing suddenly with unusual, atypical, unexplained symptoms probably needs a Lyme disease test. So looking specifically at facial palsy, this probably occurs quite early, within the first 1 to 3 weeks. Obviously, a blood test might not be relevant at that point. Patient may or may not remember a tick bite unless you ask them. We know that steroids seem to get, if you treat with steroids at that, without, in a case of Lyme disease, you may end up with a much worse outcome. Other surveys have shown that probably EM rash only occurred in 30% of people, of children with Lyme borreliosis. But if there was an EM rash up on the head or neck, that might well fit with a facial nerve palsy or result in one. And some evidence from down in the Southampton area suggests that there really need to be local guidelines in areas of high risk for managing facial palsy in children. So really, it may be difficult to differentiate between the two. So the point is to take a detailed history, raise the possibility with the patient. Certainly bilateral Lyme disease, bilateral facial palsy should raise concern about Lyme. And you're going to have to decide whether you treat with steroids if you're quite sure it can't possibly be Lyme, whether if you've got a definite diagnosis, go with antibiotics only. And if you're unsure, you may have to go with both and then see if you can get a result back. And I think probably children with Lyme, knowing that there's a high risk in children, consider always discussing the secondary care very, very early. So weeks, months, years down the line, patients may be coming in with all sorts of multisystemic symptoms. And maybe you're starting to wonder if they're another of the heart sink patients, maybe they've got some psychological problems. And they're often embarrassed to tell you because they themselves don't know what's going on. But if you look back, they probably used to be completely well, and they can probably tell you when they actually became unwell. It was described as the new Great Imitator by Dr. Andrew Pashner, and I find this story quite fascinating. This was about a 12-year-old boy admitted to a psychiatric hospital with severe OCD, to the point that he was just constantly cycling on a stationary bike, not eating, not communicating, barely sleeping, losing weight, had long before of the previous months stopped working at school, stopped eating, stopped playing with his friends. And he was so unwell, he was actually admitted to hospital. And in the history, it was apparently he'd had 4 previous episodes of pain and swelling in his knee, and it was a Lyme disease area. Pashner suspected Lyme, did a lumbar puncture, and treated him with IV antibiotics. And his recovery was really quite remarkable within just initially days, and full recovery within a month or 2. So neuroborreliosis may mimic many other neurodegenerative diseases. Now, that doesn't mean to say that these diseases are caused by Lyme disease, but whether there's any trigger in some cases, or whether it's a misdiagnosis in others. Motor neuron, ALS, as it's also known, Lou Gehrig's disease is the other name for it. It's interesting that, in fact, Lou Gehrig's family had a holiday home in Old Lyme, Connecticut. Sometimes it's misdiagnosed as MS or Parkinson's disease. Guillain-Barré syndrome, I think people are now more aware, looking for Lyme disease when patients are admitted to hospital with Guillain-Barré syndrome. Dementia has been described in some cases that has then responded to antibiotics, and often, although not specifically necessarily neurological, chronic fatigue, fibromyalgia, and cases of patients being diagnosed with FND, functional neurological disorder. Now, going back to ALS specifically, it's not just theoretical. There was some research showing significant number of patients testing positive, of ALS patients testing positive for Lyme in the USA. Other research subsequently dismissed that. But Dr. David Martz is somebody who I know personally. He was diagnosed about 15 years ago with motor neuron disease by 4 separate neurologists. He also had very severe joint pain, which isn't exactly typical, but he was deteriorating fairly rapidly. By this stage, he was in a wheelchair. He couldn't really rise to standing on his own. He didn't think he had many months left. His son read about the potential possibility with correlation with Lyme disease. He tested negative, but they decided to treat him anyway. He had prolonged treatment, IV treatment, nothing standard, provided by a colleague of his. And he recovered back to 70 to 80% of normal. And he's still alive today. He intermittently deteriorates and has more IV antibiotics. But he is a case, and there have been others, where the symptoms, although apparently due to causing weren't motor neuron disease, or actually seem to have been triggered by Lyme. Another Dr. Alfred Miller, a retired rheumatologist, discovered that his daughter-in-law tested positive for Lyme after being diagnosed with motor neuron disease. And he's done several YouTube videos regarding his concerns over misdiagnosis. Dr. David Martz has also a video you can see online on YouTube. This is the paper Dr. Martz and his colleague wrote up. Other paper, a more recent, 2014 out of France, suggesting that pure Lyme dementia does exist and it can be treated with antibiotics. In fact, Chris Christopherson, the actor, was diagnosed with dementia at some point in the past and apparently subsequently recovered after being diagnosed with Lyme disease. In terms of psychiatric symptoms, the limbic system, 2 experts in this area seem to be Dr. Robert Bransfield and Dr. Leo Shea, both in the USA. The limbic system obviously affects cognition, emotions, emotional reactivity, mood. And what they've described in detail and shown in detail with assessments is this deterioration that some patients get in executive functioning, slow processing speeds, problems with attention and concentration and memory, brain fog, which is they're describing as a brain fatigue, irritability, anxiety, agitation, depression, and dementia or dementia-like symptoms. And sometimes patients do actually say, I feel like I'm going mad. I feel like I must be demented. I can't remember anything. The anxiety seems to be, sometimes I suppose maybe anxiety at the symptoms, the lack of a diagnosis, but also anxiety seems to be part of the illness. And I think I've said this in previous presentations. The patients will say, I don't know why I'm anxious. I've never been anxious in my life and I'm just constantly agitated. And it is okay to treat those symptoms alongside the treatment for Lyme disease. Functional neurological disorder. This, as many people know, is sort of a diagnosis when there seems to be no, well, theoretically in the past, when there was no other cause. It's now suggested that there are specific positive diagnostic features. But if you look at this list, the type of motor dysfunction with paralysis, weakness, odd movements, sensory symptoms, numbness, tingling, odd sensations on the skin, seizures, faints, chronic pains, fatigue, sleep problems, memory symptoms, they're all the things I've just described in Lyme disease. And it's really very important that patients don't get misdiagnosed with this and therefore not treated. It was previously named as its conversion disorder, described as being psychogenic, medically unexplained, hysterical. And an expert in this area is Dr. John Stone, I think up in Edinburgh. And although they mention specific positive features, such as the Hoover test, which involves assessing alternate legs when you ask a patient to raise one leg and therefore disproving any weakness, he has pointed out that false positive signs do exist. And they pointed out that FND is often diagnosed for the wrong reasons, such as inability to find anything else. But if you haven't actually tested for Lyme disease, you're not going to find it. Reliance on the fact that this is odd, unusual symptoms, looking for factors such as recent stress, relying on the fact that the investigations appear to be normal, bloods are normal, scans are normal. But the important thing is that a functional disorder may occur as in combination or as a result of an organic disorder. And there's insufficient data to rule out that these could be false positive signs. And yet, as Dr. Lambert will probably describe later, there are cases where patients are literally refused a Lyme disease test on the basis that a diagnosis of FND has already been made, or a patient with proven Lyme disease but minimal treatment is then diagnosed as having FND, despite the fact that they were maybe inadequately treated or have other ongoing symptoms. So really you're going to have to, again, as I said, have a high index of suspicion, think about it in any atypical neurological cases, symptoms, cases, ask about tick exposure. Might have been years before, might have been nothing very specific, or they might remember where they were when all this first started. Examination might show other multisystemic problems. Blood tests may be completely normal. Serology may be abnormal, but a negative test doesn't exclude it. And the lumbar puncture would typically show raised white cells, raised protein, and maybe some monoclonal bands. An MRI scan is probably used more to rule out other causes than it's not easy to diagnose or have any specific findings related to Lyme. And the European guidelines say that you can have a definite or a possible diagnosis based on the following: neurological symptoms consistent with Lyme, CSF pleocytosis, in other words, raised white cells, or Borrelio antibodies in the CSF. So what they're suggesting is you need all three for a definite and 2 for a possible. NICE guideline doesn't make any specific criteria for diagnosis. And a retrospective study carried out by Dr. Dryden and team, he is the consultant microbiologist at Public Health England, followed up about 72 cases and found that most patients did present initially to primary care. Most were diagnosed and managed on clinical grounds, and people didn't insist on invasive investigations. But complete resolution was only reported in 72% of these. And management was often based on symptoms and serology and exposure rather than insisting on a definite diagnosis. Guidelines, NICE, as you know, would normally be oral treatment for peripheral symptoms, IV for central nervous systems. The European guidelines are fairly similar on that. But the assessment of all these different guidelines has really shown that although they're fairly homogeneous in their advice, they're based on moderate to low evidence studies, and more studies are needed. Previous report back in 2005, which people have probably heard of, suggesting IV ceftriaxone is comparable with oral doxy for treatment of Lyme neuroborreliosis. But what it actually showed was that 20 to 30% of patients didn't get better in either group. So although it's suggesting that's an effective and convenient treatment, it's not particularly convenient if you didn't actually recover, which means, you know, it's suggested as a treatment, but what more can we be doing after that? So other guidelines include ILADS and the Infectious Diseases Society of America. The IDSA is quite limited in its criteria. So a couple of outcomes, looking at outcomes of neuropsychiatric symptoms in children. These are both done by Fallon at the Columbia Lyme, who has a really good reputation in this area. And he has showed that the potential risk for long-term neuropsychiatric problems in children. He's also shown an increased risk of mental disorders, affective disorders, and suicide in adults. And in fact, many patients several patients that I'd seen described finding themselves looking for ways to kill themselves, even though they weren't depressed and they didn't want to die, but they had these overwhelming thoughts. Something to be aware of is to be cautious about diagnosing psychiatric or psychological problems in patients over the age of 40 who've never had any previous similar issues. Looking at the long-term outcome, one study suggested that it was all very positive and there was no substantial effect on long-term survival. However, they did show a decreased labor market involvement, which suggests that neurocognitively or physiologically, people weren't well enough to return to whatever jobs maybe they'd had before, and an increased risk of hematological and non-melanoma skin cancers, but that's not been further investigated. Looking at children, long-term outcomes, this is from 2012, it was suggested that clinical recovery rate was 73%, with facial nerve palsy persisting in 13%, and other motor or sensory deficits in about 14%. Well, that's really very significant. And it really does need more research to find out how on earth can you help these children recover fully. Is it due to late diagnosis, or is even early diagnosis requiring further treatment? And the Johns Hopkins Lyme Disease Center has, who's doing a lot of research on post-treatment Lyme disease, has said that persistent symptoms probably occur in about 20% of Lyme neuroborreliosis cases. So I think our role in primary care is to be aware of all these issues, raise patient awareness. We're now getting patients back in the waiting room, so it would be a good time to maybe, if you can, put up more posters so that people are aware of Lyme disease and tick avoidance. May is usually Lyme Disease Awareness Month. Be aware and ready to be open to this diagnosis when you see patients. Be aware of the NICE guideline and how to treat. Know when to refer, and especially refer quickly. Read code this properly, because it may just be that you're recording the tick bite or the EM rash, but if subsequent symptoms happen further down the line, at least there is some evidence of an initial infection or initial bite. And we are the specialist generalists, and I think we do have a role. If you suspect, or if this thought has occurred to you, when you make a referral up to secondary care, include that information. Include the fact that the patient grew up in Scotland, that they were previously well. There's nothing in the notes to suggest a psychological problem, maybe that that you are referring to several other specialties maybe at the same time. You're the one person who's going to see all these different issues. And believe your patients and provide support. Many of them are afraid to tell you about some of their symptoms. I've had patients say, well, I didn't really want to tell you because I thought you might think I was mad. I'm being a bit surprised when you actually do believe them, because no one's ever believed them before. In terms of educational resources, this is a great leaflet. You can download it from the Lyme Disease Action site. It was written by Dr. Sandra Pearson, who's a retired consultant psychiatrist. She was also the medical director for Lyme Disease Action for a very long time. It's a great leaflet. It's not just a one-page thing. It's quite detailed. It's about at least, I think, 8 pages, and very informative. We've mentioned Lyme Disease Toolkit previously, the e-learning module. We're hoping that might become freely available to everybody again. At the moment, it's still only freely available to RCGP members. The NICE guidelines, easy access, but again, you can go to it directly through the toolkit. LRC, obviously doing the information they're doing now. Lyme Disease UK, Lyme Disease Action. Vis-a-vis Symposiums has a very good presentation by Dr. Leo Shea. So all that information, I would encourage you, if you want to go to know more, go and read up, listen to some of these webinars, listen to the podcasts. And my last suggestion really is to look at developing a Lyme aware practice. Maybe look back at a quality improvement activity, which you could allocate to anybody, one of the registrars, a medical student, anybody in the team. There might be somebody with a specific interest to look back, maybe look at how many cases you've diagnosed, wherever you are, countryside, city, how many cases maybe over the last 10 years. Maybe ask everyone to look at either looking at the toolkit or doing the e-learning module. If there's any chance, have at least some kind of discussion, although I know there's not much time for practice meetings these days, and then do an audit, try and follow up whether there are any more new cases and what the outcomes are. But if everybody in the team is aware, there's much more likelihood that these patients will be picked up, particularly when many of them might be maybe only being initially managed either by phone or by a member of the extended team, and everyone needs to know. So I think that's really the end of everything that I need to say now. But these patients are out there. Once you're aware of them, you will start seeing them. Some of them you may already know, they may have been coming to you for a long time. So look back at maybe some of those patients where you really couldn't put the whole pattern together to make any kind of clear diagnosis. But thank you very much for listening.